like to thank, first of all, the RGC for its support and trust in our team in the past 5.5 years of this work. Why have we proposed to study congenital birth defects? It is not the most obvious pathology that comes to mind, particularly in this COVID-19 era. Nevertheless, we should realize that, in fact, birth defects affect up to 2.7 million babies each year. In Hong Kong, some 10,000 or more inpatient discharges and deaths recorded as related to congenital malformations and related disorders. So it is not a trivial condition. Identifying the disease etiology has to be the main goal in order to make an improvement in the clinical outcomes. And what's more important is that if we are able to do so, it will make a lifetime difference for these children and their families. Coming from a surgeon, it may be questioned as to whether this sort of research is indeed relevant. And it is not long ago when even Lancet would question as to whether surgical research is serious. But over the past decade or so, tremendous advances have been made. And not only have we convinced ourselves, for which we've always believed in the importance of research into congenital anomalies, pediatric surgery has now emerged as a frontier in surgery, recognized in this front cover of Lancet, because it is unique in that it is pushing the boundaries of biomedical sciences and seeking innovative and often non-surgical solutions for intractable problems. The complexity of congenital anomalies, therefore, calls for innovative solutions which require the development of genetic and stem cell research to correct underlying mutations. This relates to the inherent problem of many of the current treatment of congenital anomalies, highlighted by the condition that we've chosen, Hashbrowns disease, whereby the existing treatment is imperfect because the surgery offered to this patient requires preservation of the aganglionic's internal sphincter, which therefore does not allow it to become a curative operation. So what is Hashbrowns disease, and why does it deserve a TRS effort? The condition was described more than a decade ago, and is characterized by an absence of nerve cells in the colon. This results in neonatal intestinal obstruction, and the condition is lethal if untreated, with surgery being the only way of avoiding death. However, the condition is not widely understood. We now know it is genetic disorder, but the phenotype is very heterogeneous. So there are many unanswered questions. And this most likely contributed to the unsatisfactory outcome of surgery. So after saving the lives of the neonates, many children are faced with complications, including bowel dysfunction, of persistent constipation, soiling incontinence, and frequent enterocolitis, which can even be lethal. So the treatment, again, as I just outline is unsatisfactory. And not only is the surgery itself not a perfect operation, what we are doing is essentially the same operation for all the patients when we know that they are a heterogeneous group. So it is not perhaps unexpected that we find a lot of complications. And this presents a major healthcare burden as well as substantial psychosocial impact, resulting in both low self-esteem of the patients as well as a lot of family problems and social issues. The biology of Hashbrowns disease is intriguing. What we know is that there is an abnormal enteric nervous system in these babies. The enteric nervous system arises from neural crest cells, which undergo a very elaborate process of migration, proliferation, and differentiation along the intestinal tract. And any perturbation of this step can result in an absence of nerve cells. How it happens in Hashbrowns disease is the subject of inquiry in this TRS. When we started the TRS, up to that point, we've known a few things about the genetics of Hashbrowns disease already. First, with candidate gene approach, the major Hashbrowns gene, RET, was discovered. After that, genome-wide scan using GWAS allowed us to identify new Hashbrowns genes, including neuregulin. But you can see from the pie chart here that despite all these efforts, up to now, less than 30% of the patients' genetic bases have been accounted for. So there remains huge gaps of knowledge. What are the missing genetic factors? What are the disease-causing mechanisms? Why are boys more affected than girls? Can patients be stratified and treated according to the underlying disease mechanisms? And finally, is cell-based therapy feasible or undesirable? We assembled a multidisciplinary team consisting of clinicians, geneticists, stem cell biologists, and functional genomics specialists. And we designed a strategy that would integrate clinical data, genetics, stem cell, and developmental biology in a coherent fashion. Gene discovery will involve whole genome sequencing, transcriptomics, epigenomics in the discovery of new genes. We will have functional validation using CRISPR, genome editing, as well as mouse models to unravel the gene regulatory network system and the disease mechanisms. And finally, we will develop a set of experiments to try to solve this puzzle of sex-linked mechanisms of the disease. So the first achievement the group made was in the establishment of the patient-specific iPSC model, whereby we were able to grow from patients' fibroblasts into induced pluripotent stem cells, then differentiate along the enteric neural crest lineage. This allowed us to study the developmental biological events of migration and lineage. And here we use a patient who has Hashbrowns disease and also an associated heart defect, ventricular septal defect. So we indeed showed that the patient-derived iPSC enteric neural crest cells had migration and enteric neuron differentiation defects. Furthermore, we were able to show that the cardiac neurocrest cell lineage also displayed cardiac anomalies in the dish, but the non neurocrest cell lineage in terms of mesenchyme is not disturbed. Using this model, we integrated the genetic and transcriptomic data and identified a new Hashbrowns gene, vinculin, which is essential in focal adhesion. Correcting the vinculin mutation by CRISPR-Cas restored neurocrest function, as shown on the right, whereby we could see that there's improved differentiation, improved migration, and also restoration of normal focal adhesion size. Thus, we uncovered a new pathogenic mechanism through this integrative genomic and stem cell approach. More significantly, we completed the whole genome sequencing of over 400 short segment Hashbrowns patients. And using these data, we also combined the functional genomics with Hashbrowns iPSC cell lines and made the important discoveries leading to a publication in gastroenterology. I will go through this in greater details. The first major finding is that Hashbrowns patients have 4 times higher burden of ERB2, which encodes the co-receptor neuregulin 1 in Hashbrowns patients. This significance correlates with our earlier finding that neuregulin was discovered as a Hashbrowns gene in the GWAS, and therefore firmly established the neuregulin ERB as the third core Hashbrowns pathway, in addition to RET and endothelin. Secondly, we discovered associations of key extracellular matrix-related genes, IDG-B4 and PTK2-FAK, as new Hashbrowns genes. The importance of this is that the PTK2 potentially can link the major Hashbrowns pathway of RET, endothelin B, and ERB2 as a subcentral coordinator. And finally, this is the first important evidence to show that the stem cell niche may be as important as the cellular events in the developmental biology and abnormal development in Hashbrowns disease. Lastly, we uncovered a new disease mechanism in Hashbrowns disease, whereby phase 2 mutations were found to be more excessive compared to control. Phase 2 cleaves APP, preventing beta amyloid accumulation that damages neuron, and the mutations in phase 2 lead to defective APP processing and result in enteric neuronal death. Here you can see that the iPSC cell model recapitulates this disease mechanism. So the findings were nicely summarized in the editorial, accompanying editorial, entitled, "Even When You Know Everything, There's Still More to Learn About Hashbrowns Disease." So whilst we marvel at the groundbreaking discovery that the whole genome data gives us, it was also pointed out that even with whole genome data, we cannot predict 100% all Hashbrowns patients, because there would be many variants and non-genetic factors with subtle effects that will alter Hashbrowns risk. And that these small risks, these small effects, can determine both Hashbrowns occurrence and possibly affect our future management. Hence, the editorial looked forward for us to apply the genomic data smartly, so that in future we would be able to incorporate whole genome data as part of routine medical care. So in response to the challenge of how to unravel the small effects of other genetic factors, our colleague devised this smart program we call MARVEL, which stands for Multigranular Analysis of Regulatory Variants on the Epigenomic Landscape, that converges the small impacts of different non-coding regulatory elements in gene. And using that approach, we would identify novel regulatory elements in RET, RAS-JEF1A, and PIK3C2B. And these, if we look carefully, can converge into 5 functional networks of key disease mechanisms, which we mentioned a little bit earlier on. So finally, how about the sex-based conundrum, the puzzle? We used bulk RNA-seq analysis on a mouse model at critical periods of neurocrest cell development at E11.5, E13.5, and 15.5. And what is remarkable is that in analyzing the differentially expressed genes in these enteric nerve neurocrest cells, show that almost all genes differentially expressed at 13.5 are upregulated in females, and that the GSEA analysis suggests faster maturation and migration in female neurocrest cells. So how can we account for that faster maturation? This brings to a collaboration between 2 functional genomics groups from the Crick Institute and at Hong Kong U. When we integrate the data with single-cell RNA-seq, it was found that, firstly, the early neuronal development events could be delineated by the identification of 7 populations, of which the population of interest is this, what we call the early-born neurons. So these early-born neurons have got characteristic gene signatures. But what is important is that these early-born neurons were enriched more favorably with female biased genes, and that female tends to have more early-born neurons, which are characterized by nitric oxide synthase, NOS. When we look at the importance of nitric oxide synthase, NOS, we will realize that they are at the front of the wave of the migration, and therefore, if it is developed, it allows earlier migration and earlier maturation. So even when you know everything, there's still more to learn about. We've learned through genome sequencing that we could identify new Hashbrowns genes and novel disease mechanisms. And we could highlight the importance of stem cell niche modulation in Hashbrowns pathogenesis. Neuronal death as a new disease mechanism in a subgroup of patients. And we also were able to quantify the contribution of non-coding variants to genetic etiology. With the stem cell biology, the human iPS cell based model, where we're able to recapitulate neural crest defects in vitro, correct genetic defects. And with functional genomics, we are one step closer to understanding the female bias in Hashbrowns disease. Moving forward, what would this TRS offer? We suggest that we would be one step closer to precision and regenerative medicine. When currently we have one-size-fits-all medicine, we propose that using smartly genetic risk scores, we would be able to stratify patients in subgroups for different treatments. You would ask, how far are we from this implementation? In fact, some of this are already in practice. With the use of the genome data, we already identified something like 2% of our patients having clinically actionable variants. And also, we would have actionable pharmacogenetic variants in patients that will have impact in improving drug safety and efficacy. So this already happens in the clinic. The stem cell development allows us to develop more sophisticated models, such as this one, whereby we could incorporate the neural crest cells into colonic organoids. Here you can see that with electrical stimulation, the advanced organoid system will contract, whereas by blocking the neural impulse, this will not propagate the neurotransmission. And lastly, bridging the Hashbrowns associated variants to neural crest cells in vivo allowed us to identify, by integrating meta-analysis of genome-wide association study and mouse neural crest chromatin accessibility information, novel Hashbrowns associated enhancers, such as SPRAW4, which is differentially expressed in early-born neurons, and therefore in vivo functional characterization of these enhancers would be relevant. So we have been proliferative, productive in having multiple publications in prestigious journals such as Lancet, Gastroenterology. Awards been made to the principal investigators, and we have enriched the next generation landscape with the completion of training of 12 research postgraduate students, 11 postdoc fellows, and at least 4 of our team members have been promoted in their academic careers. So we hope that a successful future and a children's first approach in these resilient children will bring us fruit and happiness. Thank you very much.
One of the questions that we have is that what is the implication to other congenital disorder, either monogenic or complex disease? Is there any implication that you can learn from your studies?
Thank you. We'd like to think of this as a prototype. As I mentioned at the beginning, rare disorder is sometimes neglected, but it is very fruitful both to make advances in understanding and treatment of rare disorder, and also to use the lessons learned to accelerate discovery and innovation of other congenital disorders. We have, for example, used a similar approach of integrating genomics and stem cell in the study of several congenital disorders. The most successful one is in the research of biliary atresia, for which we feel that such an integrative multidisciplinary approach can change the paradigm to such an extent that we will take the disease out.
Okay. So I think we have time for another questions. Is there any finding from this study that will provide more insight into the alternative therapy to Hashbrown? Because right now you say that surgery is the only treatment at the moment.
Yes. So for the very severe patients, resection of extensive segments of bowel will result in what we call shortcut syndrome. An ideal solution for these patients is that since they're only defective in one cell population, whether we could introduce cell-based therapy for these patients. And I think that this is possible now that we know what's the genetic defects that these are, that we can differentiate iPSC cells into functioning neurons, at the same time correcting underlying defects. So I think this is much closer to clinic than before. Secondly, what is perhaps also exciting but conjectural at this moment in time is the discovery of the importance of stem cell niche genes, which gives us the opportunity that we may also be able to alter cellular event like awakening dormant progenitor cells within the bowel of the patient instead of full-blown cell therapy, and that would be like by the introduction of niche factors